My name's Emma Wiley. I'm a microbiology registrar at University College Hospital, London, and I'm also the Healthcare Infection Society ALIF Infection Control Fellow this year. The fellowship funding has given us the opportunity to work in a whole health economy way, we believe, and also to utilise quality improvement methodology to reducing our E. coli bloodstream infections. So I hope that this session will be quite practical and helpful in terms of actual sort of takeaway tips that you can go back and use in your clinical settings, as you know, the idea that this is sort of under-resourced is on everyone's lips at the moment. So the overview for the afternoon is I'll be sharing sort of 10 tips from my own experience around reducing E. coli infections. I'll then be handing over to Sophia, who's a student doctor at UCL, who'll talk about how we've involved the public and patients in our quality improvement work. So we did some patient interviews, patients with E. coli sepsis, and she'll be showing some quotes on the patient experience. Then we have Ian Taylor, who chairs our Hydration and Nutrition Steering Committee, and he'll be talking about our E. coli hydration working group, which has also invited primary care to look at how we can improve trust hydration. And then finally we have two trainees from Islington who will be talking about their use of the Target UTI audits and their plans to use the Target leaflets to improve the care that GPs give around, the advice that GPs give around self-care, which includes hydration and also safety netting. And then we'll have the Q&A. So I think the question we've all been asking ourselves is, how do you cut an organism by half by 2021 when it doubled every 20 minutes? It's a challenge, I think. And tip number one, I think, is attaching national data to national targets. So this is probably one of the best papers we have on E. coli risk factors. And we've been using its recommendations, such as a UTI association and a catheter association, to drive what we do. But we have much less data on preventability and evidence-based interventions that work. And in a research active centre like UCLH, it's challenging having these conversations with people who ask you, what's the evidence? So I suppose it's a plea to everyone to publish anything that you're doing. And also, I've discussed with Public Health England the sort of need for more data to drive what we do. And tools, practical tools, are often very helpful, such as the financial model for helping busy clinical people move forwards. Tip number two, build your team. We learnt the hard way that probably the least effective way of getting people from other disciplines to get involved in infection control is to invite them to your meetings. It's better to go to them. And so we've done a lot of that this year, often over a cup of coffee, often one-to-one, of sharing what the vision is and why we think other disciplines would work very well with this. And so we've built up a team which includes not only microbiology and infection control, but also our quality and safety lead from the CCG, a continence nurse, dietitian, and so on. And we've been supported by lots of other professionals across the trust, including patient experience team and prescribing advisors. Tip number three is write a plan. So this project charter template I obtained from Quality Improvement, there'll be many on the internet, but a very short 2 to 3 page summary of what it is that you're aiming to do, what it is that you're not looking at, what your timelines are, who your stakeholders are, and why this fits in with trust values. And this has been really helpful to share with all stakeholders at all meetings. So we conducted our own prospective analysis of the first 30 hospital onsets, so post-48-hour E. coli bacteremias at UCLH. And unlike the national picture, our commonest focus was neutropenic sepsis. So this chart on the left is a Pareto chart showing you where 80% of the problem is. And the dark blue bars are the hematology wards. So this is where our hospital onset E. coli bacteremias were drawn for the previous financial year. And that directed our targets and our focus to haematology initially. Our data also suggested that half of our hospital onset E. coli had a urinary catheter at some point during their stay, and that dehydration was common, although it was difficult to pick out a clear parameter for assessing this, but there were comments in the notes about patients being dry, constipated, etc. Tip number 4, print off driver diagrams. So a driver diagram is another quality improvement tool which summarizes your change plan in a page. And it has your aim, the things that drive your aim, and then your change ideas. And you can see that our focus has been on catheters, hydration, and education. This has been really helpful, and I think preferable to a 10-page document, because you can wave it in front of busy clinical infection control teams' noses, and you get instantaneous feedback on your ideas. Tip number 5, explore PHE's data capture system and QI software. So how many people here have a DCS login? Quite a few. And how many of you have actually pulled off your E. coli data from that software to drive your improvement attempts? So slightly fewer. So a very helpful meeting I had this year was with our local PHE, and she showed me how to actually pull off our weekly trust-specific E. coli numbers. You can also export the data to spreadsheet, and it even plots out graphs for you. And that's exactly the sort of data that can then go into quality improvement software. So we've been using LifeQI, which is free to access. And these are our weekly hospital onset E. coli bacteremia rates since April. The main purpose of this chart, so this is a statistical process control chart, and the main purpose of it is to show that if you've made an intervention, that it's been statistically significant. So you should see that the chart will pick up that change. Tip number 7 is to network and engage stakeholders. So I enrolled on something called the Executive Shadowing Programme that our trust do, where you can join management meetings, executive board meetings as a trainee and gain that experience. And through that, attended the Nursing and Midwifery Board, and through that discovered that we had a hydration policy that was due for an update and a hydration lead, which then led to an introduction to Ian. I also enrolled on a 5-month quality improvement programme, and a lot of trusts now offer these, often for free, and it came with its own quality improvement coach. So Jackie is my current coach, previously it was Bella. And both Bella and Jackie have introduced me to nurses, and which I think is really important in a big trust, that sort of personal introduction that has enabled the project to progress. Our trust also offers something called Coffee Connect, where once a month you're introduced, you're sort of matched with someone random in the trust, and you sit down and have a coffee. And it just so happened that the chair of the Deteriorating Patient Steering Committee was my match at just the right time. And so we ended up being on the following agenda. And that was great because their focus is patients who are about to deteriorate with sepsis. And that enabled us to reach A&E and AMU. And then we've also disseminated our findings to stakeholders like microbiology. And this was picked up by the chief executive, who noted that our catheter management was involved when a microbiologist reviewed a patient on a ward. Tip number 8, find the bright spots. So this is an expression taken from the book Switch by Chip and Dan Heath. I think Westmoreland Street, our trust, is a bright spot. We've got lots of catheters, but not very many E. coli bacteremias. And we've been working with a continence nurse and actually sat down and did a multidisciplinary audit with her. And it was amazing. I learned lots of things about techniques such as instiller gel insertion and Neiman tips for having non-traumatic catheter insertions. They've got a wealth of information. And our audit suggested that people knew why they should and shouldn't put a catheter in, but actually they were less likely to consider alternatives to indwelling catheters. So we put together this catheter decision tool, which prompts people to view catheters as invasive devices and suggests alternatives such as in-out catheters or assisted toileting. And we also found that people didn't always successfully refer to urology, and so we've put the on-call urologist phone number on there. I'm sure they'll be grateful to us for that. So hydration and the CCG will come on to in a second. So just to sum up, we've done, in terms of what we've achieved so far, I think we've spent most of the year really collecting data, disseminating data, and kind of setting up our plans. So we've shared our findings with microbiology, infectious diseases, haematology. We also presented at FIS this year. We also requested that PHE update the primary care UTI guidelines to choose alternatives to nitrofurantoin in the presence of fever, because I suppose we're concerned that upper urinary tract agents should be used when indicated. Our infection control nurses have conducted a trust-wide catheter audit against the high-impact interventions, which has demonstrated that more needs to be done around documentation, and that will be relayed to clinicians. And we've also updated our male catheterization training for nurses to include a slide on infection control. And we noted that catheter insertions were often in the nursing notes, but they weren't part of the medical dialogue. So we've requested that they put those in the medical notes. And finally, our continence team have secured funding for a catheter trolley pilot, a bit like a sort of cardiac trolley, so that all of the equipment is available in one space. So if that's successful at Westmoreland Street, that can be rolled out. So thank you to everyone involved in the team and our funders, and I'll now hand you over to Sophia, who will talk about the patient experience.
So, okay, my name is Sophia Vieira and I'm a second-year medical student at UCL. So I've been involved in this quality improvement project, and as part of it, I've been able to speak to a few patients with E. coli bacteremia at UCH. And I'd just like to spend a few minutes talking to you about their perspective of their infection and also our project. So why should we involve patients in quality improvement projects? Well, ultimately, patients are the end goal, and all the aims for quality improvement initiatives are to improve patient care. It also gives an opportunity for healthcare professionals to educate and inform patients about their conditions and ways that they can prevent them. So for instance, in our project, patients were very keen to know more about the link between dehydration and E. coli bacteremia. Hearing what patients have to say also allows the improvement of services and also ensures that we provide a world-class standard of care. And finally, it gives a human perspective to any quality improvement initiatives carried out. So to involve patients in our project, we first of all had to liaise with the patient and public involvement team to find out more about the process and any issues that might arise with confidentiality and consent. After that, we obtained a list of patients with E. coli bacteremia in the previous fortnight. And then after obtaining consent from senior nurses on the wards, as well as the patients, we were able to speak to 4 of those patients. So here's a couple of highlights from those patient interviews. So generally, we found that there was a lack of awareness. For instance, there were a few misconceptions. So patients often believed that they had obtained their infection from being in hospital. And when they found that this was not the case, they wanted to know really what they could do to prevent it in the future. One patient was also surprised to find out that her infection was most likely due to her chemotherapy. So perhaps patients on chemotherapy should be informed of this risk and signs to look out for that they might have this infection. Patients also wanted to know more information. So they asked questions such as, what is E. coli bacteremia? How is it caused? Which were questions that were not answered by their medical team and not addressed as well. We also found there should be more information available about catheter-associated infections, as well as more information available about the link with dehydration as well. So patients were asking us, what's the recommended intake of fluid a day? Even very basic questions such as that. And finally, we realized that patients were generally very supportive of a greater selection of beverages on the wards. So one patient said to us that after his chemo, tea just didn't taste like tea anymore, and he preferred orange juice, but relied on relatives to bring it in for him. So here's a few quotes of what patients had to say to us. I'll just give you a few seconds to read through them. So overall, you can see that the patients that we spoke to, they didn't have a great understanding of their condition. And so perhaps future education might be critical in preventing these infections in the future. And again, the issue of not having a variety of drinks available on the wards is once again highlighted. So what about our next steps? Well, we plan to conduct drink surveys on selected wards at UCH in order to find out more about the drink preferences of patients. And the aim of this is to produce a drinks menu in order to improve the hydration of patients. We'll also be running a trust-wide hydration campaign with posters for patients as part of the Hydration and Nutrition Awareness Week in March. And finally, we'll be presenting our work at the Trust Sepsis Day also in March with a recommendation that staff really explain what E. coli sepsis is, how is it caused, and what patients can do to prevent it, including catheter care. So that's the end for me. Thank you for listening.
My name is Ian Taylor. I'm the head of nutrition and dietetics at UCLH. And I'm a little bit nervous about talking about hydration because it's such a huge, big topic and such a huge, big subject with so many knock-on effects and connotations. But I'll do my best to rattle through in 5 minutes or so. As Emma mentioned, she and I very much crossed paths at a nursing and midwifery board that I'd just found my way onto as well. And in the Trust, we were talking about we really need to focus on updating our nutrition hydration policy, but as an organisation, we really need to do more about really developing a fit for future food and drink strategy as well, which is now mandated under the Better Hospital Food Standards under NHSI. So we've got a huge piece of work in front of us, but what I've really focused on is some of the work that we've been doing most recently, obviously in relation to E. coli bacteremia. So my main point to start off with is obviously about defining hydration. What do we mean by dehydration? I think broadly as infection control prevention nurses and an audience such as this should be aware of that. But I think what we need to highlight is the impact of hydration on everything. So we're not just talking about E. coli bacteremias, we're talking about other infections, but also pressure ulcers. We have a huge focus on pressure ulcers, particularly in our organisation, which is very high profile. There's constipation, urinary tract infections, AKI, cognitive impairment, dizziness, falls, poor oral health, and skin conditions. The list is very much kind of endless. So we know that water is essential for health, but despite being a fundamental, absolutely fundamental aspect of care, the identification of patients with dehydration is quite often overlooked. It's not very often documented in medical or nursing notes, and the provision of fluids can then also be overlooked as well. So good hydration is a core element of care. In terms of incidents and the literature out there, I've literally picked up a couple of data points, which are some studies have come out with a figure of about 20% in care home residents. That can go up or down depending on if those are nursing home residents or not. On presentation to hospital, there was a study I think came from some authors in 2015 from Nottingham, where they identified that 37% of a 200 patient cohort were dehydrated clinically on admission or presentation to ED, which is a significant number. And those were patients who were in the older age bracket where dehydration is going to have the most significant effect. So evidence for interventions, I've not gone into too much detail, wanting to move more around what we're currently doing at UCLH, but there is evidence primarily coming from nursing and care home settings, which is why it is so important that we link in with the community and why we link in with our CCG counterparts and commissioners, that staff can lack knowledge of fluid requirements and risk factors for dehydration. And that's why I think we've all got a multidisciplinary role in this to play. As a dietitian, I know that we've got an understanding, we've got some expertise in nutrition and in hydration, but actually it's the nursing staff, it's the HCAs, it's the volunteers, it's the ward hostesses who are ultimately absolutely key and central. And also thinking about those older, frail patients, we also wanted to involve particularly our speech and language therapy colleagues, thinking about those patients who are very high risk or vulnerable because they're on modified consistency diets. So there have been some studies showing that fluid intake can be improved. I'm kindly hopefully going to be added to a community sharing lots and lots of hydration resources, which I've just found out about this afternoon. But I know there is some fantastic work that's going on that has already shown significant reductions in admissions. And one of the key ones that our consultant in infection control forwarded on to me was the one from Kent, Surrey, Sussex Academic Health Science Network, which I think was not too long ago last year, which looks absolutely fantastic from the report that I just had an opportunity to read. So in terms of nutrition and hydration, I wanted to kind of present also where this fits into our wider journey so that we weren't starting at a given point and talking about our plans, our next plan, which is a patient survey in terms of hydration. So UCLH were really fortunate. I don't know if there's been another one, but we actually had the Darcy Fellowship for nutrition and hydration, which was last year, which was fantastic. So I'm not aware that another trust have done that. And that really undertook a deep dive into practice, not only patients' meal times and eating experiences, but also their drinking experiences as well, because that's when we were encouraging patients to drink. We had a nutrition and hydration conference and learning event with about 120 delegates at UCLH last year, and from that we got 65 champions. So I have seen from the literature, what you really need is people to champion the cause. You need to champion something like hydration because it is the bread and butter, it's a fundamental of care, it's something we need to keep, we need to train, but it needs to be remembered. So what we have is every one of our wards and then some have a nutrition champion and a hydration champion. They're both combined, and it's the most motivated person in that ward area. So typically it's a HCA, sometimes it's the ward sister, sometimes it's a therapist, but it very much depends. And that's being led by one of our CPFs, who is having a regular ongoing forums and maintaining that. We've also developed a mealtime standard operating procedure as well to kind of say what is the exemplar process and practice around mealtimes, and that includes beverages as well. That includes making sure that hostesses are providing drinks to patients before or after their meals. It makes sure that it's clearly outlined what the role of the volunteer might be, and that they can also do drinks rounds around those times, and that we're recognising choice. And lastly, we very much embraced the quality improvement agenda at UCLH. So I was on the same quality improvement course that Emma was on, actually in the same cohort. And the Trust has also been, it launched an exemplar ward accreditation program, and part of that, each of the ward teams were encouraged to undertake improvement projects in their areas, and quite a few of them have gone, let's do something on nutrition and hydration. So two of them that were particularly pertinent was one of our wards, T16 North, which won an award. It developed a drinks trolley in haematology, where a lot of our patients were in side rooms, and T8 Infection, where they actually developed soup rounds, which, again, as you know, soup and other foods can contribute significantly to hydration status. And there was something about that, about either having it as a role that the volunteers could take on, or it being a role that the ward sister or the charge nurse did, because actually then that meant they were visible, and it was about ward leadership and the patients also seeing the members of staff as well. So that's been very, very popular. So E. coli, in terms of a springboard to further hydration work. So we established a hydration quality improvement working group at Emma's request. We had a coffee beforehand. It's a good job I'm a coffee addict. And so we met up and we had a conversation and thought about who were the best people to kind of involve in this, and came up with so many ideas that I think the driver diagram that Emma came back with was huge. So we had to kind of very much tone down the ideas, and we're going to have to think about which ones we go for next. So we've particularly focused on the base of E. coli data, so we've targeted by ward, but we've also thought about those susceptible, older, vulnerable adults as well. So as I've already mentioned, we've got a patient hydration survey, which has been designed with the whole team's input, and we're going to look at patients' experience, choice and perspectives very much along the lines of some of the work like the iHydrate work in West London that was asking the basic questions about, well, what do patients usually drink? What would you like to drink? How would you like that presented? It could make a significant difference. Hydration awareness as well. So what we've currently tasked some student dietitians, some medical students and a variety of others with is going out there and pulling together all of the resources and designing us some really great resources that we can have on our nutrition and hydration boards, some resources that our nutrition and hydration champions can use, and also information that we can use to train staff as well on hydration. And the last one, you may or may not know, it's Nutrition and Hydration Week coming up on the 12th to the 18th of March. So a big focus this year is on hydration, which is a fantastic opportunity. We've not previously, certainly our trust, engaged on the same scale, but we certainly haven't focused on hydration before, so that's something that we're going to be doing this year. Enabling change in practice. There was a lot of other things that we've had to think about along the way, which really sound very, very much basic things. But we talked about access to beverages. Quite often, although I manage the service, I also see patients clinically, and you hear patients saying, all I was offered was tea, or all I was offered was very much a jug of water. And if they had a jug of water, then it might have even been behind them in a side room, it might have been out of sight, it might not have been in the right place. And what we actually found that we had was we actually already had in what they called enhanced beverages. We already had herbal teas, decaffeinated coffees, we had a range of juices, we have a range of cordials, but staff themselves and the patients weren't aware of them. So that is, again, one of those things, actually saying to the trust, picking that out with those who manage the contracts in terms of catering and soft FM and saying, this is really important, this is something we need to keep, this is something for hydration that will make a big difference, and taking that forward. And then what we'll do is we'll publicise that, and also we can adapt that depending on what patients tell us that they would like. It was competency in assisting and positioning patients, so we've supported our volunteers and included nutrition hydration, not just with actual assistance with eating and drinking, but also mealtime companions. We found that patients in the mealtime raid that a Darcy fellow did actually fed back most of the time. They wanted assistance opening juice packets to allow them to drink them. It wasn't the fact that they couldn't drink themselves, it was the fact that they couldn't actually access packets of either food or drinks or other beverages. Really, it was a case of looking back and looking at our catering contracts. We have 4 catering contracts across one trust. So it was going back and saying, well, what are we being provided with in terms of beverages? What other options are there? How can we improve the quality of the service? We'd really like to look at some assistive technology later on down the line. But strong leadership and support is really required. I mean, I can speak as a dietitian, but really what we need is we need nursing on board. We are really fortunate to have a really engaged deputy chief nurse and chief nurse as well, who was very big in support of nutrition and nursing midwifery. And we also signed up, or our Darcy fellow did, signed up our chief exec, who above his computer in his office, he's got a sign saying that he's a nutrition and hydration champion, and he's got a badge. Which is really important. So looking forward, kind of like a top tip style, this is the last bit from me, is kind of to try to build that leadership, try to establish in your organisations, if you don't already link in already with a nutrition hydration steering group or strategy group, all trusts should have such a group that reports or should report nutrition hydration issues up to the board. Leverage drivers, there are so many for nutrition hydration if we're thinking about the CQC requirements about access to food and drink. Francis Hospital Food Standards, which as I mentioned are mandatory. The best practice toolkits and resources out there are numerous. Patient feedback and thematic review of incidents and complaints is really valuable as well. So if we didn't have the feedback that we do, we wouldn't be able to act and to give that evidence, particularly in terms of what we have available. Engage the whole team. So it really is, as I said, everything from procurement to facilities to frontline catering staff. Our ward hostesses, for instance, are outsourced, so they're a contractor. So we will need to make sure that we go and see them and engage with them and really value the work that they're doing, because they're the ones who are really delivering that care. They're the ones giving the meals to the patients. They're the ones doing the drink round. Thinking about access, choice and knowledge, but that's both for staff and for patients. So it's not just that knowledge about hydration for staff, but it's also the patient's own knowledge as well. Do they understand how much they need to drink and what the importance is, as we've mentioned? And lastly, contributing to the evidence base to support nutrition hydration and the huge impact that it can have. So the cost of malnutrition in the UK, in England actually alone, is 19.6 billion, but we don't actually know about hydration, do we? Because it's undiagnosed, it's missed, it's often not documented, so we don't know that it goes missing. There's a number of, so many resources and references, as I mentioned. One key one would be the Nutrition and Hydration Digest, which the British Dietetic Association published and brought out the second edition of very, very recently, if not within the last couple of months, which is really very useful. And there is lots of peer-reviewed information sheets out there that don't need to be reinvented, like the British Dietetic Association Food Fact Sheet, which gives really good, clear information for patients and staff on hydration. Thank you very much.
Hi, so I'm Janky and this is Coroner, and we are both final year GP trainees at an Islington CCG practice whose primary link to secondary care is UCLH. And we got involved in a project with Emma from our perspective in the community, as we're often the people that first see patients with lower UTIs, and to see what we can do to prevent patients being admitted with E. coli bacteremias. So we have started an audit, and we're currently in the first stage of this audit. So we've looked at our current management of UTIs at Amwell Group Practice for a month prior to intervening and seeing what we can do to improve this management. We are then planning to do a teaching session to all of our clinical team at the practice who come into contact with patients with UTIs and introduce the target leaflet, which Coroner will show you a bit more about later. And following that, we're going to re-audit to see if there was an impact of our intervention and hopefully see better management of UTIs in the practice. So to conduct our audit, we did prospective data gathering from the month of January. And for those of you that know EMIS, we searched for codes of patients that were seen with the following codes. So suspected UTI, UTI, site not specified, and we reviewed the notes of these patients to see how they were managed. We then put all of this data in the following table, which is quite small on the screen, but it basically says whether patients were given immediate antibiotics, delayed antibiotics, what the course they were given and how long they were given it for, and what advice they were given at the time regarding self-care and safety netting advice as to when to come back, and whether we were distributing the target leaflets. So I think now Coroner's going to give you those results.
Yeah. So these are the results of the first stage of our audit. So they showed that we were quite good at prescribing antibiotics, so 90% were given immediate antibiotics, and of those, 97 were given the correct choice, but only 81% the correct duration. We were not quite so good at giving the safety netting advice or advice on management of symptoms. We focused more on the treatment with antibiotics, and we could definitely do a lot better about giving advice about the natural history of the disease, because only 15% were documented given advice about that, and only 2.5% were given advice about antibiotic resistance. 0% were given the target UTI leaflet because we haven't yet introduced that into the practice. So the plan for the next stage of our audit is to do a teaching session in one of our clinical meetings at the practice where all the clinical staff who would be treating urinary tract infections are present. At that teaching session, we're going to introduce the target UTI leaflet, which I'll show you on the next slide. We also are going to discuss the results that we've got so far and things that we found that we might be able to improve. So particularly the things we were not so good at were discussion and documentation of the natural history of urine infections and self-management and antibiotic resistance. So we're going to think about how we can improve that in the future to give patients a bit more information about what they should expect from treatment of a urine infection and what they could do to help themselves. So things like hydration are really important, and maintaining their fluid intake, and also a bit of information about antibiotic resistance and the importance of that. We felt the antibiotic prescribing was actually quite good. We're very good at prescribing the correct antibiotics, but we're going to do a bit of an update on the correct duration. It seemed in this case it was just a particular locum doctor who's not one of our usual doctors had been giving a slightly unusual duration of 5 days rather than 3, but apart from that we've been doing quite well on that. And then following that teaching session, we plan to re-audit using the same criteria and the same EMIS searches to see if that teaching session and the UTI leaflet has improved our management of UTIs in the community. So this is the target UTI leaflet that we're planning to roll out, and the plan is to give that to anyone that we're diagnosing with a possible urine infection, to give them more information about the symptoms, the self-care that we advise, and a bit more information about types of urine infections, and what to do, how to get help if things are getting worse, and what you can do to prevent further UTIs in the future, and a bit of information about antibiotic resistance. And I think that would be really helpful at giving patients the information that we sometimes struggle to give them in a 10-minute appointment regarding all of those things. So that's the end.